with selective use of radiation or surgery. Evidence-based treatment plans for MSI high or MMR deficient locally advanced rectal cancer. So what are the questions that they started with? This was a clinical scenario to say in this patient, what are the different options we can adapt to. He was a symptomatic patient with a upper rectal growth, which was T3N plus. So whether it is the standard, so they've given different options, whether the standard chemoradiation followed by surgery followed plus or minus adjuvant, or TNT trials, or because it is MSI high, neoadjuvant dostarlimab or nivolumab, or can we avoid radiation in them? The staging we already know, depending on depth of invasion, the T stage is decided, and N, apart from N plus, even the subserosal deposits and all are included in N1C. So here, T1, T2, you can resort to upfront surgery, especially in higher rectal tumor. Previously, T3, T4, N plus, we were resorting to surgery plus or minus adjuvant. So this has gone through a lot of revolution. So what was the complexity or the clinical complexity that we have when taking rectal cancer decision? So here the local recurrence risk is somehow taken care by your radiation or chemotherapy, but distant recurrence risk and difficult anatomy. Pelvic is a space constraint for operability of recurrent tumors. So these pose a lot of clinical challenge compared to colon cancers alone. So for this, there were aggressive therapies were undertaken, like potential excentrations for salvage surgeries, which had there would not be R1 resections, where only 20% to 30% there were R0, and lot of post-op complications, which spanned between 15 to 68%. So from 1986 to 2020, they have taken through the evolution of rectal cancer management. So in and around the 1986 era, there was standardization of rectal cancer procedure as a modality to reduce your local recurrences was taken a part of solution. So when you write about TME, you have to mention about the surgical and as well as pathological reporting of your TME specimen. So you will resort to en-bloc sharp dissection of rectal mesentery, which includes blood supply and lymphatics, and pathologically assessed TME should have complete mesorectum without defects, no coning with smooth circumferential margin. So in the era of neoadjuvant therapy and TME, what was the risk of local failure? Initially, all of the rectal cancer management was to reduce the local recurrence. So let's see how much of it is reduced. Is it single digit, or it's between 5 to 10%, or it is in about half of it, or more than 70%. So the whole of the management is divided into pre-TME era and post-TME era, because pre-TME era, they showed adjuvant or neoadjuvant form of RT had overall survival benefit, because this was attributed to that inadequate surgery falls was taken care of by the adjuvant or neoadjuvant treatment. But when we standardized the surgery to TME, the local recurrence rate was controlled to about 5 to 10%. This did not translate into overall survival benefit. So RT, yes, added to TME, decreased the local recurrence to about 5 to 10%. So here you can see in German RC trial, it's about 10% in the adjuvant arm, neoadjuvant 7.5. So it proved that pre-operative RT had better local recurrence, local control. So adding with TME, there was local recurrence benefit, but it did not translate into overall survival benefit. So that gave to a next question. When there is local control by good surgery and RT, why was this not translated into OS benefit? then they wanted to see, should they intensify the therapy in order to gain OS benefit? Then different sequences of RT was given and chemotherapy was started incorporated in the pre-op setting. So the question here was how to tackle the distant failure. That led to neoadjuvant chemotherapy era. So the distant failure was almost about 20 to 30%. Then came to TNT. So they wanted to intensify the pre-surgery by giving all the chemotherapy prior, so that the percentage of patients who received this therapy was high. There was better conversion into pathological complete response, such that the time to treatment and ileostomy was decreased. They can resort to conversion treatment, and there was another modality added to this, that there was an opportunity for organ preservation, that is non-operative management. So what are the trials they wanted to? Here mainly they've concentrated on the organ preservation. Here you're not only intensifying the preoperative treatment, but you're trying to also de-intensify your surgical option by wait and watch policy. So what is the probability of regrowth in a patient who's put on wait and watch after TNT? So the previous question of local recurrence, the answer was about 5 to 10%. Here, if you resort to wait and watch, how many people will have regrowth, and what is the stage that the patient will present at the regrowth? So here they've concentrated on OPRA trial. In OPRA trial, what we have to understand is there is no standard treatment arm. The two arms that they have used is two different modalities of TNT, induction versus chemoradiation. So they wanted to see which has better PCR, which has better organ preservation, which has better OS-DFS, and how many patients with TNT went into non-operative modality. So your endpoints is not just the two arms were surgical. There was not a non-surgical endpoint as well. So this was conducted in 18 centers, phase 2 randomized trial. The primary endpoint was disease-free survival. Now, whatever the in-between course of the disease or non-operative or whatever it is, at 3 years, how the patient behaved if followed TNT and de-escalated without surgery. And they also compared the adverse effects. So quite naturally, those who had trimodality treatment, that is chemo, RT and surgery, definitely had more advanced event compared to non-operative management. So in OPRA, what else you want to understand is NCCN has adapted the surveillance of patients in NOM. The per protocol, whatever the study had included, that has been adopted by NCCN as well. So there are some descriptors. If you do, there are specific timings when you call the patient for digital rectal examination, for endoscopy, for tumor markers and imaging. And when do you decide to consider surgery? So by endoscopy, complete response if you see a white scar or telangiectasia, but there is no evidence of any macroscopic disease in the form of ulceration or nodule. Digital rectal examination should be normal, and there are sequence T2 weighted and DWI is seen for some characteristics of fibrosis versus evidence of viable tumor. Next, if there is presence of complete response, you should have all these factors. If any one also is missing, then it becomes incomplete response. Now, what and all they saw? So, tumor regrowth in non-operative management, about 36 to 40% of the patients had tumor regrowth, and they saw this trend mostly within 2 years. When they presented with a regrowth, it was a mucosal confined disease, non-metastatic, which was still operable, and it gave outcomes similar to upfront TME. So percentage of patients who had organ preservation was as high as about 50%. Here they've given two distinction, 41-53 for induction and consolidation arm. To summarize, you should know that consolidation arm definitely had a better PCR, definitely had a better TME free 3-year survival, but not very clinically significant. So both had outcomes in organ preservation, but not clinically very significant. So this gave an opportunity for organ preservation. So the 5-year disease-free were similar for those who underwent TME upon recurrence. So they had survival about 61%, which is comparable. So this is the NCCN surveillance method. So you will call frequently, that is 3 monthly to 6 monthly for a physical examination and a tumor marker. You will resort to do proctoscopy or sigmoidoscopy, not colonoscopy at 3 monthly interval for first 2 years, 6 monthly at 3 years. Imaging is done at 6 monthly for local staging MRI, 6 monthly for distant metastasis, that is chest, at 6 monthly or 1 yearly up to 5 years. Colonoscopy is done 1 year after your diagnosis, and according to normal guidelines you follow this, but otherwise frequently it is sigmoidoscopy. This is same with even per protocol OPRA trial as well. So this is a non-operative management. Because this radiotherapy had long-term side effects, especially increasing, mucosa-related complication and sexual dysfunctions in patient leading to apprehension, they wanted to de-escalate. So they wanted to select those patients with good response to avoid radiotherapy and its complication. So in this direction, they have two trials, that is FORWARK trial and PROSPECT trial. FORWARK trial had 3 arms. So it had neoadjuvant chemoradiation with 2 different regimen. 5-fluorouracil was arm A, FOLFOX was arm B, and only FOLFOX with elimination of RT was arm C. So they followed up. It was done as phase 3 RCT in 15 Chinese facility, seeing around about 495 patients with, here the selection was low tumors which were advanced. So T3 and beyond were all included. So when you see the chart, in all these 3, it is matched. So they have similar proportion of patients in equal distribution, all beyond T3 and N plus mostly, and there were lower rectal tumors in 40% of individuals. So in this, what they when you see the 10-year DFS and OS, it is comparable in only chemo or chemo RT arm with FOLFOX or 5-FU. But there was a lot of caveats, and it is not very accepted, but still it was presented in ASCO 2023 because there was no negative outcome. It was still comparable. Coming to prospect trial. In prospect trial, it is your response as adjustment management. So you will omit radiation only if the patient responded by more than 20% response to chemotherapy. In that subset of patient, you can omit your radiation. So they designed the study including predominantly T2, T3, T4 were excluded. So all those which were aggressive and more aggressive in biology, that was excluded, and more than 4 lymph nodes were excluded. Here, there was no role for organ preservation. Here, the standard regimen was compared to giving 6 cycles of modified FOLFOX. Then you saw for response by MRI and proctoscopy. If the patient had a response of more than 20%, then you could safely omit CTRT, go ahead with surgery, and give adjuvant according to your histopathology. Whether it was free of margin, you resorted to give chemotherapy. It was R plus resection, then you added chemoradiotherapy also. So this here, mostly tumors were of meaning good biology. If you say by location, they were all higher tumors, and predominantly T3 and T4 were excluded. And the results said that 5-year overall survival, R0 resection, and PCR were comparable if the chemotherapy did its job as good as radiation. So you can omit giving chemo radiation to them after your chemotherapy. They also studied the patient related outcomes in this study. So they found that the quality of life in terms of anxiety, sexual function were worse with radiation incorporated in your management. So they wanted to summarize that radiation could be omitted in selected mid and high locally advanced rectal cancer. This could eliminate chemo radiation related toxicity. But the other thing is extremely well selected patients were used. So whether the adoptability for a larger population is not really, it is not inferred. Then they came up with the role of molecular biology, whether circulating DNA was trying to tell you to select your stage 2 patients for chemotherapy or not, or if your MSI had an implication in increasing your PCR rates. So this is the new recommendation added to NCCN, where MSI high tumors who received 6 months of dostarlimab, which is category 1, or nivolumab, if they had pathological complete response, then you can resort to wait and watch policy. So this is the new NCCN template where a dostarlimab or nivolumab is given completely for 6 months, reassessed for the status. If they have complete response by endoscopy, digital, and MRI evaluation, you can put them into wait and watch. If they have persistent disease, or they have in any time of surveillance it recurs, then you will follow your standard role of chemo RT followed by radiation plus or minus adjuvant therapy. The newer thing is also circulatory tumor DNA in the blood to tell you whether you can adopt to give adjuvant therapy in stage 2 rectal. They say there are benefits in colon, but whether this can be extrapolated to rectum is still under trial. So to summarize, total neoadjuvant therapy has a potential for non-operative management. That is, in 50% of them, you can resort to preserve their rectum. They have good systemic control as well. What are the caveats is, here you are giving radiotherapy in one or the other form. Still, in an intact rectum, there is potential side effects. You have to put the patient on close surveillance, and there is potential of over treatment of T3 lesions, where you could have just done a surgery and given them no side effects of radiation. Next, with omission of radiation, you're targeting to decrease the later toxicity, that is infertility and for sexual functions, fertility, and secondary malignancy. The other thing here is you're not just eliminating RT or substituting RT with chemotherapy. So chemotherapy related toxicity is there. Here there is no role for organ preservation. So the surgical related complication still exist. Then TNT with short course, RT with chemo followed by TME. Here they've highlighted the advantages and disadvantages of short course radiation. So here the regimen is short course RT, so it will finish earlier, and there is an improved compliance of the patient to therapy. The caveats is still surgical procedure is involved, and radiation oncologists feel short course radiations have a longer, toxicity at a longer period of time later. Next is the standard regimen. Here, the standard regimen has many trials to support evidences and practices. There is a potential to avoid chemotherapy. The caveats here is there is no intensification, so downstaging and PCR is not as much as TNT. So there is still delayed systemic failure, and option of non-operative management cannot be resorted. Here, de-escalation by using dostalizumab. Here, okay, this is for MSI. Yeah. TME followed. Okay, this is low rectal or high with director of descent. TME followed by surveillance. So if you just give, this is the older where local recurrence for high T3N0 is quite low. You can, okay, this is for high rectal tumors which mostly behave like colon. You can do upfront surgery itself, avoiding the toxicity of RT. So that's all.
वेटन वॉच से शुरू किया था क्या? Given to achieve sustained response. ये दो चीजें याद रखना. इम्यूनो इज फॉर सस्टेन. द बायोलॉजी बिहाइंड इट इज आप इम्यूनोथेरेपी देके आप अपनी खुद की ट्यूमर म्यूटेशनल बर्डन को यूज करके अपने इम्यून सिस्टम को एक्टिवेट कर रहे हो बिकॉज विथ न्यू एंटीजेंस. तो योर इम्यून सिस्टम इफ इट इज गुड इनफ इट विल बी अ लॉन्ग टर्म इफेक्ट फॉर यू. जैसे वैक्सीन होता है ना, 2-2 साल पे लेनी पड़ती है ऐसी कोई वैक्सीन. मतलब कहने का मतलब ऐसा है. तो इम्यून ओ थेरेपी ऑलवेज फॉर एंड दैट इज व्हाई सीए स्टमक, सीए कोलॉन, ये अपने जो सीए पैंक्रियाज इन मेटासिटी सेगमेंट जो आर सिस्टमिक टू बिगिन विथ. मतलब नेचुरल हिस्ट्री डिसीज की सिस्टमिक होती है टेक्निकली. वहां पे इम्यूनोथेरेपी का रोल ये लोग ज्यादा लेके आ रहे बिकॉज आ ही रहा है अभी हर जगह. कहीं कहीं मेरे को लग रहा है
हो जाओ वरना पूरी रेजिमेंट ही चेंज हो जाएगी.
नहीं, अपने अपने बच्चों के टाइम पे ना सर ऑन्को सर्जरी विल बी एक्सक्लूजन वाला ब्रांच हो जाएगा. भाई ये नहीं हो रहा तो इसको ऑपरेट कर लो. इट्स नॉट लाइक अगर डेफिशिएंट एमएसआई आई नहीं है और नॉट रेस्पॉन्डिंग देन यू गो. हाँ वही. कोई ठीक, बढ़िया, नाइस.